Hello everyone, welcome to generic competencies session. This is something I think is a very important session because whenever somebody sends me its feedback form for the part 2 exam, I always find that the generic competencies is the one which is largely missing. Hope I am clearly audible and the voice is clear. Would like to hear from you all. Please chat, just write in the live chat if you can hear me clearly. It certainly would be helpful to know if I am clearly audible so that I can continue further with the session. Please chat, just write in the live chat if you can hear me clearly. Yeah, good evening, very good evening. Thank you. Yes. Okay, great. That's very good to know. Okay, so let's start. So basically, as I was telling you, that generic competencies is one topic which I have always seen in all the feedback forms that it's largely missing. And many of the students do text me also that what is actually included in the generic competencies and how we can improve on it, right? So it is very important. Even if we do not know what exactly it is, then it becomes very difficult. And I think we all are doing this as a part of the curriculum, but we are not focusing too much into it because we believe that this is something we already know and we practice and we can make it happen. So let's dig this topic in some details, although it's a very huge topic, but yes, certainly I'll be covering few of the points and giving you a proper roadmap of how you can work on this particular topic. So mastering generic competence is the hidden key to part 2 success because it's a very important part. Don't let non-clinical questions be your reason to fail. So here we go with MRCUG courses and ensure your success in 70% day study time, as we always say. So what is actually the generic competencies is? What are generic competencies? Ethical decision making. So that's one of the very important part. Patient safety and risk management, consent capacity, confidentiality, data protection, breaking bad news, the good communication skills, the leadership skills, multidisciplinary teamwork, dealing with the complaints and the conflict, duty of candor, and the clinical governance. So, multiple things. They are basically the competency, your competency to make you a safe, efficient doctor. So, if you follow these norms, which the NHS, RCOG, GMC are looking for, then you are a safe doctor, and that's what the NHS is looking for. So, to judge that whether you are on the right track of becoming a person like that, they are, of course, there are large number of questions related to these topics. Now, because what happens is we know that these questions are coming, but we think about these questions as some kind of like maybe this is a better answer. Maybe if I would be in a situation, I'll do this, that. So, like this, we try to make up the decisions. But actually, that's not how it works. There are proper rules for it, and it is very important to know the rules, the regulations, the laws behind it, and particularly the concepts behind it. For your EMQ, it's always very important to go through your concepts. So, why are these so dangerous? They look very simple, but they are the most failed category, not covered well in most books. We don't have any green top guideline for that. We don't have any nice guideline for that. Many of the books even do not have the questions about it. So we do not get lot many questions. We really rely on whatever recalls are available. Need the UK NHS mindset, not just medical knowledge. Sometimes you may find that when you are answering the question, you are medically right, right? But that's not what NHS is looking for. So I already told you it's more about looking at you as the effective and the safe doctor. So let's dig further details into it. Where actually the students go wrong. Skipping the non clinical topic, assuming that they are not important. Oh my God, this I'll do. I absolutely know when to take the consent, what can be done with the consent, without the consent, and how to deal with the situations of sexual offenses. We have been doing this in day and day out, but so think that not it's not important to know in details about it, but choosing what feels morally right instead of what is NHS compliant. This is the biggest mistake, because what we think morally right and what is actually morally right may not be what the ethics is followed in the NHS compliant, because it is not about just being a morally right, it is about legally right as well. So you have to look into that also. Guessing in ethics questions without clear strategy. Another big mistake, and the very common mistake, particularly, I would say. So ethics questions are there, and you just think about it like from your knowledge, whatever basic you have, and you go and take the answer. But a clear flow chart or the strategy is not there. In today's session, we will be talking about the unexpected things which come up during the surgeries, and a flow chart and the algorithm about dealing with these situations. We are also going to talk about the questions, but I'll definitely give you algorithm as well, which you can follow to answer such questions whenever they appear in exams. Non-practicing these scenarios under timed SBA conditions, and then confusion in best and the correct answers. What you think best may not be the correct in view of NHS. So we need to understand what is best and what is correct. So let's go ahead with this. Here we start with the questions. So as you can see, I'm putting up a theme for the question, right? Because as I have already listed, there are so many themes. We are going to take at least 4, 5 themes for today, and we will talk about the questions related to that. So the first question comes from the communication skills. Now, you don't have a green top guideline or the nice guideline for that. So, where does this topic come from? There is a very good lesson in the RCOG e-learning, and this is something comes from there. We need to know the concepts of good communication skill, because this is one of the non-technical skills which is very important while you are practicing. So here we go with our first question. And I'll be waiting for your answers in the chat box before opening up the correct answer. So be ready. Be ready to write the answer. 24-year-old woman with a history of chronic pelvic pain has recently had an ultrasound of her pelvis, which has been reported as normal. You are meeting her in the outpatient clinic today for the first time. She is very upset and has told the nurse that she feels like no one is taking her concern seriously. The woman reports that the ultrasonographer made a comment about her ovaries during the ultrasound, and she is worried there is something seriously wrong. So very common scenario in our OPDs. A woman, she has been suffering from the chronic pelvic pain, and when she underwent the ultrasound, she was told that nothing is there. So she's largely disappointed because she feels that nobody is taking care properly, and that's why they are missing up the diagnosis. But she is also concerned that the ultrasonographer actually mentioned something, that the ovary has something wrong. So, what is the most appropriate approach during your consultation? Let's see who is the first person to answer this question correctly. So, what are your options? Assess the woman's ultrasound result on the computer while you listen to her. You can check exactly what she is saying is correct or not. Ask questions to check your understanding of the woman's concern. You need to further interrogate the patient. immediately make a phone call to find out who carried out the ultrasound, or you would like to contact the sonographer, why it is not mentioned in the report, and what was actually what he saw. Remain silent while the woman is talking. You are just listening to the woman, what she is taking, and giving her time. Take extensive notes while she is talking, or you want to make the extensive notes while she is talking. So, which will be the correct answer? Yes, I'm looking at few answers, waiting for more. Please, everybody try to answer. It will be a helpful thing if you answer, you will be remembering in the exam also. So, very, very important that you start answering. Yes, good. Good. So everybody here is the right. So basically, and Dr. Srinivasan Geeta, that's thumbs up for you. You have won. And you answered the first question. You were the first to answer the question absolutely correct. So ask the questions to check your understanding of the woman's concern. See, D option also seems to be okay. D option is remain silent while the woman is talking. You may think about, like, you may sit and listen to the woman carefully, is a good communication skill, but it's that you need to check her understanding. You need to actually find out where the things are not aligning. So, asking the questions to clarify is a better communication skill rather than just simply sitting silently and waiting for the woman to talk. So, B is the correct answer. The correct answer is ask questions to check your understanding of the woman's concerns. Asking the patient questions to check that you have understood is a good way to demonstrate that you are listening and that you think that what they are saying is important. Try to avoid the distractions. That is absolutely wrong that you are making some notes, you are taking the phone calls, looking at the notes or the computer, as this can give the impression that the woman is not the focus of your attention. However, active listening is not the same as remaining totally silent. Active listening means you are echoing, you are telling something, right? So you are engaged with the patient. So even a simple phrases like yes, go on, or like something or demonstrate, you are engaged. So that's a good communication skill. So very good attempted. So here is another question for the communication skills. 35-year-old pregnant woman attends the antenatal clinic at 34 weeks of gestation to discuss VBAC. Her 10-year-old son accompanies her. You notice that she has failed to attend two previous appointments. It quickly becomes apparent that the woman speaks very little English. However, her son is a fluent English speaker. Her mother in law is in the waiting room and speaks good English too. What's the most appropriate way to continue this consultation? Very important point, because in the recent memories, when they were looking at the causes of the mortalities, so one of the important factor which came into account was that there was a problem with the language. Language barrier has been a very important topic. And you can expect actually one question on the language barrier in your upcoming exam. There was a question in the last two exams also. So same you can expect right away also. So what are the options here? I would expect somebody else to answer the question first, and so that we can have another winner today for this question. Looking forward for who is going to answer this first. So here are your options. Ask the woman's mother-in-law to interpret. Obtain a professional interpreter for this consultation, telephone advice. Reschedule the appointment and book a professional interpreter. Use the woman's son to interpret and use very simple words so that woman understands. Yes, I could see two options here, B and A, in the chat box. So, yes, the correct answer is B, and the winner for this question is Dr. Yashasvi Pandey. Very good. Well done. And the B is the correct answer. So here we obtain a professional interpreter for this consultation. We can never take relative as the person to interpret this, right? So always we need a professional interpreter. So confusion can occur between B and C, whether to just do a telephonic service and talk with the interpreter, or you can reschedule the appointment because this is a patient, elective patient, right? There's no emergency here. She is at 34 weeks to discuss her birth plan. So she could have waited for another. But they have given you an additional information here. So what is the additional information which is given here and which makes the answer B and not C? Which is, you notice that she has failed to attend the two previous appointments, right? So this is one word which has changed the answer from C to B because she has already paid for the previous appointment, so she may not come back and attend the appointment this time too. So therefore, we cannot wait. So if we don't want to wait, we can immediately have the interpreter telephonic service. So your A is not correct because we are not looking for the relative to go ahead. Yes, this is a good option. B is a good option. C is also a good option, but the problem is patient may miss the appointment. So for now, we are not going to pick up this. Sun is not the good way and simple words is not the good way. So B is the correct answer here. And remember, this same thing holds true for emergencies as well. Even if in emergency, we will still try to arrange the interpreter for the patient rather than relying on any other source. So, because when you look at the emergency, they give you like the patient is in for the cesarean section, you have to do it urgently, and can you take the help of the husband or some relative or the hospital staff? So no. Ideally, it should always be the professional interpreter. So professional interpretation services should be provided to all pregnant women who do not speak English. This is the dictum, and this stands true for the emergencies as well. This is very important thing because you may become confused when the situation is there for the emergencies. So using the mother-in-law is does not make sense because she may not understand, or she would be not the right person to talk about that. And of course, the son is also not a good option. Rebooking the appointment is not the best option as there is a history of missed appointments. So therefore, professional interpretation services should be provided to all pregnant women. Okay, great. So thank you for a very good participation. That really makes the session interesting and interactive. Thank you for joining. So here is the third question. This is also about the communication skills. 35-year-old nulliparous woman attends. This is slightly tricky, so pay attention to it. 35-year-old nulliparous woman attends the antenatal clinic for the scan review at 36 weeks of pregnancy. You are about to transfer her back to midwifery led care when you note that she has a birth plan which states very clearly she is not willing to have an instrumental delivery under any circumstance. You explore this with her, but she remains adamant she will not consent to the instrumental delivery. What is the most appropriate next step to ensure this potential problem does not become a source of conflict? So basically, the patient, she is here for the review, but she does not want to go for the instrumental delivery. You have tried to console her, you explored why she does not want, but she is still adamant. She is not ready to consent for the instrumental delivery as of now. So, what is the most appropriate next step to ensure this potential problem does not become a source of conflict? Because later on, if anything goes wrong, that there can be a conflict which can come up here. So, what is the correct answer? alert the supervisor of the midwives, ask the consultant to see the woman, ask the woman to rediscuss her birth plan with the community midwife, and document the discussion and her wishes clearly in the hospital records. Refer her to see the psychologist. So these are the various options. What could be the correct one? See, I told you this is a tricky question. So I'm again giving you a clue that you have to think what you can do to actually ensure that the problem does not become the source of conflict. So, most of the answers which I can see in the chat box are D, right? I'm still waiting for the winner of this question. Yes, yes, yes. Anybody else would try to go ahead with that? We try to answer it. Okay, okay. I think I have a winner, but that's showing by the name of user. So I don't know. It's the A is the correct answer. There is the name of by the user and Dr. Hadia. Dr. Hadia is also written as A. So there are two winners because I don't know who user is. So we are taking up two winners here. So that's so basically A is the correct answer here. D is a good option, right? We do that. Whenever the patient is not willing for something, we definitely do that. We try to discuss, document the complete discussion and her wishes clearly in the hospital records. That's absolutely fine. But the problem is what? Is this going to do settle out your responsibility? Or if any conflict arises, that this will be the one point. So we need to be prepared. Of course, we need to document the discussion and this all in the hospital records. That's a must thing to do. But simultaneously, we have to make the preparations that we are ready to handle this situation. So A option gives you that flexibility. It alerts the supervisor of the midwives because that way you will be prepared. So the answer is alert the supervisor of midwives. The consultation in the antenatal clinic gives us the opportunity to highlight and discuss the potential problems that could be encountered when a woman presents to a delivery suite in labor. This can also be a valuable time to discuss these potential problems with other members of the staff, including nurses, midwives, juniors, doctors, and other colleagues who may be on call when these women present. If a woman has a birth plan that you are concerned may put her on her or her baby significantly at the risk. So first thing is to alert the colleagues and the supervisor of the midwives who may be called upon when she is in labor. This may help to reduce the potential conflict. So that's why what I said in the very beginning, which in general may sound to be a best answer, may not be a correct answer. So this is a clear-cut example of that question. The D option seems to be very good because you are putting up that discussion in the hospital records, but yet that's not the best thing to do for this patient, particularly if you look at this particular sentence, the potential problem does not become a source of conflict. So basically, you are trying to get over the problem. So that can be by alerting the supervisor of the midwives or alerting the staff and making them prepared to handle this situation effectively, right? So therefore, A is the best answer. Does it make sense? And yes, I've already announced the winners, user and the Dr. Hadia. Great, thumbs up for you for answering. This was a tricky question, but yet you managed to answer. So very good. Is this point clear? Is this point clear? Yes, no, would like to hear from all of you. Is this clear? Because it's a typical question, different type. We don't expect this answer, so would like to hear from you all. Is this good for you? Yes, would be looking for something. Mhm. Okay, great. Yes, okay, great. Thank you, thank you, thank you. Thank you for being such an amazing audience. Thank you. So, coming on to the next question. Now, this is something a nightmare for all of us. We always have questions from this. Something unexpected finding during the surgery. The theme for the questions is intraoperative discovery of unexpected findings during surgery. Seems to be a nightmare, but not so, and not after today's session, because we will be talking about an algorithm which you can use to answer these questions. Of course, I'm going to take up 2, 3 questions about it, but then I'll give you the algorithm also so that you can answer any question effectively. So here we go with this particular topic. So here is the first scenario. Unexpected ovarian mass during sterilization. A 34-year-old woman undergoes laparoscopic sterilization. She consented for the bilateral tubal ligation. Bilateral tubal ligation only. On inspection, a 6 centimeter right ovarian mass with irregular surface and papillary projections is found. She is otherwise well and not aware of this mass. No prior discussions about oophorectomy or the cancer risk were held. So patient is undergoing the laparoscopic sterilization, and there is 6 centimeter right ovarian mass, which of course have some concerning features like papillary projections, but you already have not taken any consent. So what would be the most appropriate action here? Remove the unexpected finding without further consent. Do not proceed. Retain the unexpected finding and close. Proceed only with what was consented. Contact the patient's legal next of kin for consent. Pause and seek consent when the patient regains capacity. Proceed as clinically indicated despite lack of consent. Document and arrange the staged procedure later. Seek emergency consent under best interest clause. Convert to laparotomy and remove without delay, and terminate the procedure and escalate to legal team. Oh, okay. Yes. Yes, so I can see two answers here. Two answers, B and C. B and C. Two things I can see here, right? So which one? 2B is important or C is more right? Both of them, they are slightly close to each other, right? And I could easily sense that what is the problem here. So basically, in B option, it says that do not proceed. So do not proceed means you will not do the laparoscopic sterilization also, right? And of course, you are not going to do anything to the ovarian mass and you will close the abdomen. While the C says that proceed only with what was consented. That means you can go ahead with the laparoscopic sterilization, but you will not touch the ovarian mass. So, yes. So yes, that's the correct answer. Oh, okay. So here comes another option. That's G. So document and arrange the staged procedure later. So we can just document the finding and later on we can arrange the staged procedure. Okay, another G coming up. So yes, so this is a big confusion here. So B, C, and G. Three things, three confusions. So uh, can we do, my question is, can we do laparoscopic sterilization in this patient safely? Can we do? Or will it make a difference to this patient if she has ovarian mass? Would you like to carry on with laparoscopic sterilization? Oh, yes, no. What do you say? Can this be done safely? Yes. Yes, it can be done safely, right? Yes, thank you. Thank you for answering. So, yes, it can be done safely. So, why we do not want to do this? So we can do this, but yes, everybody agrees. All the three options B, C, and G mention that we will not touch the ovarian mass. So C could be a best answer here. Proceed only with what was consented. Because if we choose B and G, then we are saying that we will not proceed with the laparoscopic sterilization, right? So we cannot proceed with the laparoscopic sterilization if we choose B and G. But here we say that we can proceed with the lap sterilization. So that way, C option becomes best among all of these, right? So C option becomes best of all of these. And again, the first winner, the fastest finger first was Dr. Hadia. So very good. And you again, you are the winner and you got it right. Yes, others are also answering right. There are many students who have answered it right. But the winner is the fastest finger first. So that's it. Okay, so here is another point. Can do with 6 centimeter. No, it's not a point about the 6 centimeter. It's important to take the concept right. It is not about the point of 6 centimeter. It is about the point that if we have taken the consent for sterilization, we can go ahead. And later on, we can figure out what type of a mass it is and what type of a surgery or the treatment it requires. And we can go ahead with that, right? So, yes. So, what is the point tested here? The key ethical reason for this question is respect the autonomy. Respect autonomy means do whatever patient has decided for herself. Proceed with only what was consented. Only the sterilization was consented. So removal of an adnexal mass not previously discussed or agreed breaches the autonomy. Unless life-threatening, further surgery must be delayed. Okay, now coming to the next option here. Okay, sorry, what happened? Okay, so the next here is the remove. Then this is again the same topic, same we are going to talk about the discovery of unexpected findings during the surgery. So again, this is the, so basically in this again, it is the, this, sorry, there is some issue with the screen. Okay, so we can make it, I think, full screen. Hmm. Yes. So here we are perfectly fine now. So again, the same concept here, same theme we are testing here, intraoperative discovery of unexpected findings during surgery. So here is the next question. Now the 29-year-old woman who is undergoing the diagnostics, laparoscopy and dialysis for infertility has grossly dilated hydrocephalus on the left. No prior consent for self-injectomy was obtained. So you believe it affects the fertility options. Now, what is the correct answer? Yes, now what is the correct answer? So here is, can we remove? Do not proceed. Proceed only with what is consented. Mhm. Okay, proceed only with what was contact the patient's legal next to kin. Pause. F. Okay, so we have got the options as C, B, and F, right? C, B, and F. Till now, I have the options here. So what does the guideline says for this? Basically, the guideline says that can we do the we were doing the diagnostic and lab test and we find out the hydrocephalus. So can we go ahead with that? Of course, we can't go ahead with that. So what else we can do for this patient is, for in this particular scenario, what else we can do for this patient? So basically, we cannot actually proceed with this. Yes. Yes, yes, coming up, answers coming up. Yes, yes, yes. Keep answering. Thank you. Thank you. So three C answers, B, F, and C are the final one, right? So now look at this. So C means proceed only with what was consented. But here, a diagnostic lab has been done, right? We don't know whether she consented for any additional procedure or not, like self-injectomy. So proceed with what, right? Do not proceed, retain the unexpected finding and close. In this, we can't do anything. We don't know. So actually, do not proceed. Just wait, because you cannot do the self-injectomy without the patient's consent. Looking at F, proceed as clinically indicated despite lack of consent. Oh, this will be a blunder if we do this, right? Because you cannot proceed clinically for removing a tube, even if it has hydrosalpinx. Patient does not want to get it removed. So we are not bound to do that. And then G option also come, document and arrange stage procedure later. So nothing to do with that. So this patient is basically, again, it is the B option, which is the correct one. So B option is the correct one. And that's great that Dr. Hadia and Dr. Srinivasan Geeta, they are again the winners here. So, what is the key ethical reason behind it? Impacts fertility and needs informed choice. So, patient, it is going to infect the fertility. You are going to remove one tube. So, it needs the patient consent. So, do not proceed, retain the unexpected findings and close. Now, you try to understand the difference between the B and the C, right? B and C options. The C option also seems to be right in this because we say that do as consented. But the problem is that we were doing diagnostic lab and we don't know what type of a consent was there for what particular procedures we were allowed to do. So we cannot go for that. In the last question, it was very clear that patient was posted for lab sterilization and she has given the consent for bilateral tubal ligation. So we were very clear what we can do. So therefore, that way in that question we chose it as do as consent. In this particular question, it's not clear. It's not clear what we were consenting for. Only we know that we were doing like diagnostic laparoscopy. So therefore, we cannot proceed further in this. So therefore, this B option here and not C option here. Self-injectomy will impact the fertility and the future options. Without informed consent, you should not proceed, discuss findings, and re-consent later. So that's how the B option is there and not the C. And F and G, of course, do not hold true here. I hope this point is clear why we are choosing B and not C here, because you need to understand the difference between the two. Then only you can get to know the best and the correct answer. I think the one thing which I told you in the very beginning, that best answer should not be sometimes may not be the correct answer. So now you understand what that situation meant. Okay, is it clear? Shall we proceed further? Is it okay? Everybody fine with this question? Yes, no? Would be happy to hear from you all. Okay, yeah, so fine. So this is the third EMQ about the same. Now let's see, let's explore. This is again a different kind of a concept which is going to come up here. So here, a 25-year-old is undergoing the laparoscopy for ovarian cystectomy. On entering the abdomen, a ruptured inflamed appendix is found. On entering the abdomen, a ruptured inflamed appendix is found, and the patient is febrile, and the surgical team includes a competent surgeon. Right? So now what is going on here? Yes. Okay. Yes. So here, she's undergoing a laparoscopic for ovarian cystectomy, and you find a ruptured appendix. Patient is already febrile, which she says that she might be in a sepsis. So, and you have a competent general surgeon here. So what can we remove? Remove the unexpected finding without further consent and proceed. And another option is F. Proceed as clinically indicated despite lack of consent. Okay, so I've got two answers till now in the chat box, A and F. So which is the correct one? Yes, waiting for more answers. Everybody try to look at it from the NHS or the RCOG point of view. Um, yes, yes, more answers. Only two? Mm-hmm. Yes. So basically, what is the difference between the A and F? I can understand that's the confusion for you all. So basically, A also says the same thing, that we can remove this without any further consent, and that's fine because it is ruptured. So we need to remove it. And the second one, F, says that proceed as clinically indicated, which means that clinically what the patient needs, we proceed with that, right? So, and okay, here is another option, that's I, which is coming up in the chat box. So I need to clarify that as well. So convert to laparotomy and remove without delay. Uh, do we really need to convert to laparotomy? That depends on the surgeon's skills, right? Because it is not that always we need to remove that. We can go ahead even if competent surgeon is there, as rightly mentioned. So I does not stand here to. Regarding A and F, I definitely understand there is an issue. But see, A just mentions that you remove the unexpected finding, while F gives you a clear intent that you want to do what is clinically required for the patient. So F gives you a better intent as compared to A and gives a specific reason why you want to proceed. So therefore, F is the better answer as compared to A. So I'm happy to announce that this time we have a new winner, Dr. Vinisha Modi. She has won this question. So thumbs up for you. So this is basically F is the correct answer. Proceed as clinically indicated despite lack of consent. The difference between A and F is the intent. F specifically tells you that yes, this is required, right? So that's how we proceed. Now, decision-making flow chart, right? Decision-making flow chart. So this is unexpected finding. How do we go about this? How do we go about this particular thing? So unexpected finding. Okay, just wait. Unexpected finding during surgery. Whenever we have a unexpected finding during surgery, we look at as, is it life threatening or emergency? Is it life threatening or emergency? If it is a life threatening thing, then proceed if in best interest or emergency. And if it is life threatening, we want to proceed if it is in best interest or it is in emergency. Yes, it is to be required. We will proceed. If it is not life-threatening or proceed is not that important, then we can just stop and document it. Now you will be thinking, what is the difference between the uh, life, the life-threatening and the emergency, right? There are two terms. So this is life-threatening and the emergency, right? So emergency means urgent, okay? So now life threatening, not all urgent situations may be life threatening, right? We may need to do something urgently, but that is not absolutely life threatening, right? Urgent means you have to do it now, maybe in next 1 2 hours, but life threatening is if you do not do, you may lose the patient. So therefore, it is very important to understand the difference between these two words. So if it is in the best interest of the patient, we can proceed. If it is not, we can stop and document. If it is not an emergency, then then we have to look at the another thing. Was it previously discussed? Like a patient who is undergoing a diagnostic laparoscopy, if already mentioned that if any problem will be there in the tube, that may be required to removed. Okay. Now, when you see the hydrosalpinx, you can proceed. But in the scenario which we discussed, there was not mentioned that what was exactly consented for. So we pause and document the plan later. So that's how it makes the difference, right? So pause and document the plan later. So was it previously discussed and consented? So this is how you need to see. If it is life-threatening or emergency, you have to see whether it is in the best interest of the patient. If it is in the best interest, proceed. If not, stop and just document. But if it is not an emergency, just see whether you have previously consented for it or not. If you have not consented for it, then it is pause and document and plan it later. Okay. Any confusions about this? Does this flow chart makes you uh, understand how to answer these questions? Is it okay? Yes. Is it fine? Yes. Decision making flow chart. Does this helps you? And if any questions regarding this. So mnemonics and the concept pointers for such questions are consent, respect the consent. If not discussed pre-op, don't touch unless emergency. This is the dictum we have to follow. A, B, C, D rule for intraop. A, act in acute emergencies. B, best interest only when no other option. C is consent rules if not given. Pause. D is document and delay if unsure. E is escalate when the legal or the ethical gray area is there. So A, B, C, D, E rule. A is for act in acute emergencies. B, always see whether it is in the best interest. And C is the consent rules. If not given, pause. D, document and delay if unsure. Escalate when legal and the ethical gray areas are there. So this is how we need to proceed further. Life-threatening means hemorrhage major? Yes, massive hemorrhage, where patient is absolutely bleeding and she can just bleed to death. That would be life-threatening, right? So this is how we will follow the rules for the concept questions. Now, the few more questions. So this is about the Sexual Offences Act, legal scenario. This is also a repeatedly asked question, right? Where to inform, whom to inform. Often students ask me when to inform the social services, when to inform the safeguarding. So these types of questions are always there. So that's what I'm going to talk about here. So in this question, 15-year-old girl is pregnant by her 19-year-old boyfriend and her parents are not aware of the sexual nature of their relationship. Okay, so whom we are going to inform? Which team or the group of individuals should be informed regarding this relationship? A named nurse and the midwife, or her parents, social services, general practitioner, the police, whom we are going to inform here. Yes. Okay. Very good, very good. I think everybody knows the answer. Very good. That's good to see all my students answering right. Right? They know that where to do what. So that's great. So social services is the correct answer, and Dr. Mavish is the winner for this question. Very good. Congratulations. So here, the social services is the correct answer because see, this is a girl, 15 years, who has a right to go for the sexual intercourse. But because of this age difference, right, 15 and 19, that's the problem here. So therefore, we are informing the social services, and this is the risk behavior here. Police is only one answer when you have FGM in a woman less than 18 years. Nowhere we have to go for the police. No. Police of 6 years age gap between girl and boy? No. No, not at all. It still remains the social services if the girl is elder than 13 years, right? 13 years and above. So I'm just coming to those rules so that you know. In case of the minor, the if the age gap between the minor and his or her partner is more than 4 years, then social services should be involved. Sexual Offences Act 2003 states that. So what is this? So basically, what are the bullets for this act? So it states that the age of consent for sex is 16 years, and sexual offences legislation will not be used to prosecute mutually consenting sexually active between under 16s unless it involves the abuse and the exploitation. Big gap, any big gap, whether it is 4 years, 6 years, 8 years, whatever it is, can be worrying and refer to children's social care should be considered. There may be issues around grooming or exploitation. To protect younger children, that is, children under 13, because under 13 they cannot consent, they have no right to consent. Even if they are going for consensual sex, then also it is considered to be sexual assault only. So in this care, so children to be reported to social care and the safeguarding. Okay, safeguarding will take care of who will advise on the involvement of police. You are not directly involved to involve the police here. You are going to inform the social services and the safeguarding if both in options together, right? If the option says social services and safeguarding, you can choose that option. But if there are two different options, social services is a different option, safeguarding is a different option, in that case, you will go with the safeguarding, right? So that's how it proceeds. Fine. I think that's okay now. Good. Okay. So the concept, fine. Now, coming to the next question. The parents of a 22-year-old mentally handicapped woman came to see you in the gynecology clinic requesting sterilization for their daughter. The woman had recently become sexually active and she describes it as a very nice and fun. Her partner is a member of the care home she lives in. She does not understand that her actions may lead to pregnancy and she thinks it will be nice to have a baby to take for walks in a garden. The lady will not allow a pelvic examination, and an implant inserted a few months ago was removed with the fingernails or the fork. Can you show the question again? I'll go back, right? But right now, let's finish this question. So, how would you manage this case? Okay. So, here, 22-year-old mentally handicapped girl is there and she is in relationship with sexually active with someone who is a member of the care home and she does not understand what the pregnancy is and she's not allowing the pelvic examination and implant which was put up but she got it removed. Okay, so C and D. Okay. Refer the case to the court for judgment is C, and D is refuse to perform the sterilization as the woman is not in a position to consent to the treatment. Okay. So the correct answer, I already tell you, we have discussed this also previously that whenever we have to go for any permanent procedure, right? Because sterilization is a relatively permanent, right? Reversal is there, but obviously this is like taking a permanent kind of a decision. So you need to go for the court for judgment, right? You need to go to the court for judgment. So, because whenever you use the contraception, sterilization as a contraceptive method without consent, then you don't have the right to do so. If she was for Mirena, then definitely you can proceed, but that is already ruled out because not allowing the pelvic examination. So, refer to the court for the judgment. This so the answer is refer the case to the court for judgment. In this scenario, the woman lacks the capacity to consent to treatment and not providing a reasonable form of contraception. would be detrimental to women's well-being. Woman does not understand the implications of her actions or pregnancy and may not ever understand them. So, for this reason, it is advisable to get the legal input as the decision cannot be based on the parents or the guardian wishes. So, always remember the dictum is anything which is temporary, right? Anything which is temporary, like putting up Mirena, can be done in the best interest. But when we are doing something permanent like sterilization, we have to go for the legal advice. So that's what the dictum is, and we need to follow. Okay. There was a question, a request about this question that I should go back here. So in this, basically, there is a difference, age difference, 4 years, which makes this relationship maybe high risk, right? So therefore, we are referring this to the social services. But if we talk about the girls less than 13 years, where actually they do not have the right to consent because very younger age is there, so in that case, it becomes the safeguarding. Okay. So just remember that where the risk is low, like in these girls who understand 15 to 19, this age group will have social services, and the one below 13 years will be safeguarding. Okay, fine. So these are certain exam shots. Circumstances when a referral should be made to the courts for a ruling include sterilization for contraceptive purposes and donation of regenerative tissues such as bone marrow, withdrawal of nutrition and hydration from the patient in a persistent vegetative state where there is a doubt on the patient capacity or the best interest. You should always go for the legal route. And the winner for this question is Dr. Malika. That's great, great, great thing. Okay. So here we go on to the next question. I think one, two more questions are there. So you have supervised as an ST1 trainee perform their fifth cesarean section. You had to perform the uterine incision, deliver the baby, and secure the angles. The trainee performed the rest of the operation. You were called to attend other emergencies and reviewed the cesarean section. Operation notes 3 hours later. The notes indicate that the ST1 trainee performed the entire operation. So and that's it. So here I mean, the ST1 has done half of the operation, but in the notes he have mentioned that he has done the complete operation. So what to do? Mhm. Okay. Yes. What can be done for this patient? Can we just go ahead with that, or what would be the best answer here? One of the option which I can see in the chat box is the G right now. So what another things can be there? Okay, so what could be the possible answer here? Mm-hmm. Yes, yes, yes. G, G, N, N, G, N, and G. Right. So what is N and what is G? N is ask for rewritten notes and give the trainee a verbal warning. And G is ask for rewritten operation notes and inform the consultant on call. So G is the correct answer. Oh, okay. We have H also here. Okay, so H is ask for the rewritten notes and do CBD on cesarean section. See, this is something because see, operation notes are the legal document, right? So it's very important that there should not be any flaw in it. So G is the best answer here. G is the best answer here. So here it is where she can go and write the operation notes here. Ask for rewritten operation notes. That is clear. and consultant should know about it, because the consultant, whatever we are working here as a trainee, the responsibilities of the consultant, right? So because he is the person responsible for this procedure being carried out, so he should have the note of this information. So therefore that is the correct answer. So G is the correct answer. N does not inform the consultant, so it's not a correct thing. And even the H also does not do so, right? So that's the correct answer here. So G is correct. Dr. Suraya, she has won this question. So again, great. Uh, Great. Thumbs up for you. Oh, okay. So there is another question here. Ma'am, can we put Mirena with parents' consent if there is no contraindications? Yes, we can go ahead if you as a doctor think that this is in best interest of the patient, then you can take the decision along with the family members to insert a Mirena. Okay, fine. So here G is the correct answer. This is needle stick injury, another important thing. 35-year-old asylum seeker is undergoing a category 1 cesarean section on the Friday night because of placental abruption. The woman has declined HIV testing. During the procedure, your assistant sustains a needle stick injury. Now what? What you can do for this? What is the most appropriate step for this patient? You are on the Friday night performing the cesarean and got a needle stick injury, and the patient was asylum seeker. Now what? And HIV status is not known. So what to do for this patient? Yes, F A, mm-hmm, F and A. Okay. So these are the two places where you need to contact, right? If there is any needle stick injury. Oh, B is also option here. So attend the accident and emergency department immediately, or contact the occupational health department immediately, or okay, BH is also there. So B is blood test for rapid HIV test from patient, and H is HIV and hepatitis C test from doctor in 3 months. Right. So these are the various options here. Now, first thing is you have to contact, right? Because if at all the antiretroviral therapy, that is post-exposure prophylaxis, need to be given, then it needs to be given as early as possible within 2 hours. So now, in this case, who will give the heart, right? Heart needs to be started, but who will give the heart? So, and decision of giving the heart is also to be taken. So that is why he has to go to some place. Now, occupational health is will not be open on the Friday night. So Friday night is the clue here. So in Friday night, that would not be open. So we cannot choose we cannot wait till the Monday. If we wait till the Monday, the window is over. So right now we can go to the accident and emergency immediately. So F is the correct answer. And this time, Dr. Mavish, she is the winner. Yes. So again, great. Awesome. So thumbs up for you. So attend the accident and emergency department immediately is the correct answer. So now, whenever there is a risk of HIV infection, post-exposure prophylaxis should be started within 2 hours. During working hours, this is obtained via the educational health, and out of hours, it is via the accident and emergency. So that's how it works. Okay, so if it is in the daytime, office hours, you can go to occupational health. If it is in the emergency, you can go to out of office hours, then you go to the emergency. Now, what is the significance of the exposure? You have to see what is the exposure. Blood, serum, plasma, and all fluids contaminated with blood, laboratory specimen, semen, and vaginal fluid or saliva. Now, what is the contact? What is the significant contact? Is the percutaneous injury, contact with the mucous membranes, contact with non-intact skin. And you have to see what is the risk profile of the behavior. So like this patient, she is at a risk because she is asylum seeker, so high risk of their sometimes the option of washing with water is given. That is, if they ask you what is the initial or the first step. See, in EMQs, this is very important. that you know that whether they are asking about the first step, whether they are asking about the appropriate step, and you should be ready with all possible answers, right? So first step will be wash it with the water. But appropriate step is go to occupational health or the accident and emergency. If this is not an option, then heart will be the next best option. So you should be ready with all these sequence of options because there will be a play of words, play of the options is there in the questions for the exam. Okay. So the risk of infection following the needle stick exposure to an infected source, hepatitis C 3 to 10%, B is 6 to 30%, HIV is 0.3 to 0.4%, and this depends on the viral load. The deeper the injury and injury with the device visibly contaminated with blood. Okay, coming to the next question here. 39, 13, yes, immediate if asked, then washing is preferred. Yes, immediate is washing. 39-year-old woman is undergoing total abdominal hysterectomy with conservation of the ovaries because of heavy menstrual bleeding and a large fibroid uterus. She has been waiting for the operation for 7 months. At laparotomy, there is a large fibroid uterus and with several intramural fibroids. Left ovary is normal, but there is 8 centimeter complex right ovarian mass. The bowel and the omentum appear normal. Now, what is the most appropriate thing to do in this patient? So she is for the TH, ovaries you are not going to remove in this. And she has been waiting for the operation for 7 months. And today when she got in, then you come to know that there is a 8 centimeter complex right ovarian mass. Bowel and omentum are normal. What you can do for this? Okay, so I have a C answer, I have a A answer. TH as per consent can be done. C is TH plus BSO plus omentectomy can be done. Can we have more answers here? Okay, okay. Okay, okay. So if we look at the option H, right? TH plus BSO, omentectomy plus peritoneal washings. Does this option make sense to you? Because TH with BSO, of course, BSO, we haven't taken the consent here, so we cannot do that. So what else we can do for this patient? TH with right ovarian cystectomy, can we do that? No, because we know that this could be cancer as well. So we cannot afford to get this removed. So we need to work safely. So what would be the next best answer here? Okay. So now in this question, basically the consent was with the conservation of ovaries for this particular patient, but she has been waiting for the operation for a long time. And this is 8 centimeter complex right ovarian mass. So we can still go with the TH with TH with, we would have done the peritoneal washings in this case and omentectomy. Now, because she has come in the OT after a 7 months and she is heavy menstrual bleeding, so at least we cannot close the abdomen and just send her back because that will be something not in the best interest of the patient. So definitely we need to proceed with the TH here. So basically, normally in cases where we go for the ovarian conservation type of a consent, and whenever the TH is done, it is a routine to take the consent that if there is any issue, we may need to remove the ovaries as well. So in that case, what we can do is at least we can remove this affected ovary here. So H that is TAH with the right salpingo oophorectomy. This is not BSO, this is right salpingo oophorectomy. Omentectomy and the peritoneal washings can be done for this patient. This is something which is different from the what we do routinely. Why we are choosing here that the consent for TH with the ovarian conservation should have included a discussion and the documentation of what should happen if an abnormal ovary was identified. Because whenever we plan ovarian conservation, it is there that if any pathology occurs there, then we may need to change the decision. And that's what we are going to do here. This scenario raises the possibility of the malignant ovarian mass with a normal contralateral ovary and a normal bowel end omentum appropriate to undertake the TH with right salpingo-oophorectomy with omentectomy, which can be done with the peritoneal washings, and a type of staging laparotomy can be done because see this is a young patient, so many of times which you may expect that the complex cyst can is not the malignant or maybe something like dermoid or something, so we will need the washing CS. So that is why the correct answer here is H. Particularly this, I typically took this scenario because just wanted to explain you that whenever we do the hysterectomy, even with ovarian conservation, we do take a consent of like whether we, if any pathology we see in the ovary, we may need to change the decision. So looking at this, we can go ahead with this. How general gynec can do the cancer. So if you remember your premenopausal guidelines, then a CA125 between 25 to 200, which has a complex ovarian cyst, these can be operated in the gynae center by the gynecologist. If it is more than 200, then you go to the gynae onco, right? So here we do not have the CA125, but already this is going on. So believing this, and we are doing here only one side omentectomy, not doing exactly what the onco can be done. Yes, staging is done by the gynae onco at the cancer center, but this we do not know whether this is a oncology, right? So yes, we are removing the mass. Yes, we are removing the mass. Yes. No, biopsy is never a good option. Biopsy is never a good option because if it is malignant, at least you are taking out intact. You are not breaking the capsule. If you take the biopsy, then you break the capsule and the tissue, and there will be upstaging, right? So even if you are removing, you are doing the right salpingo-oophorectomy, and you are taking this. So now the basically what needs to be checked further is the lymph node status, right? So therefore, then in that case, if at all this comes out to be malignant, she may require the second look because of the lymph nodes, right? So that's it. Why we are removing here? Because they have created a scenario like this, that she has been waiting for the operation for 7 months, right? And she has a heavy menstrual bleeding, so she needs treatment. And another dictum which is here is conservation of ovaries. Whenever we do the TAH, we have a consent of like if any issue is there, we can remove it. Yes. I thought if malignancy, we don't remove. So we actually, we are not sure whether this is malignant because 8 centimeter complex mass can be anything. Like if we had a CA125, then there is a long list. If the CA125 is between the 35 and the 200, right? So we can have multiple possible options in this. So this is one of the typical scenario. That's why I included it here so that you know how to proceed with this type of a thing. Okay. So that's it. So finally, how to approach these questions? Think like an NHS doctor, not just an exam taker. Choose the safe, ethical, patient-centered, and guideline-aligned things. Avoid what feels right, but isn't protocol-based. So choose what is protocol-based. That is the correct answer here. I hope you all enjoyed the session. Any questions? You all are welcome. Whatever I could see the questions here, I have kept answering during the session. And If you still have any questions, please leave them here. I'm still watching and I'll still keep on answering the question. So here is an invite to the EMQ workshop for all those who are appearing for the July 2025 attempt. If you are still struggling with the EMQs, don't know how to proceed with that, then we have got your back. So 3-day focused EMQ workshop is there, and it is like very, very, very reasonable, only 10,999 INR. So and you can tackle the hardest part of exam with this. And of course, we will be covering all the topics, right? All the topics which you see in your feedback forms. The topics are there. What topics the questions come. So we will be touching on all the themes of that feedback form, and it will be a 10 hours thing which we will be carrying out for the EMQ, and limited spots of course are there. So if you want to join, this is a code through which you can actually scan. You can scan and just pay for that and send a screenshot on this phone number or the WhatsApp number, or my mail ID is also mentioned below the slides. You can text on here, and you will be able to attend the workshop. And of course, the recordings will be available till the exam also. So this is specifically for those who are attending the July 2025 attempt. Those who have joined right now and they are attempted for the January 2026, for them, let me tell you, we have a full course also going to start from the July, and it includes, if you join now, it includes the crash course and the EMQ workshop also as the bonus. So that can be there. And of course, with all of my candidates around, they can just give me a shout out that what how they are feeling for this. You can write in the live chat, how do you feel about the course? Many of my students are here today in this. So we include everything, all guidelines, summaries in a very small video format. We discuss complete RTOG learning strategy questions in the live sessions. Our live sessions are totally interactive sessions. Then there are mock tests, then we have discussions going on without actually holding you long with us. We believe that you can study at your own pace, and we believe to decrease your study time by 70% so that it becomes easy for all busy professionals. And no course offers access till pass. So unlimited access is our unique feature. This is the QR code which you can scan for your this particular course enrollment. What makes our course unique? 70% less study time, structured path, and recall based learning. Study only what comes in exam. Read only what is required to pass. Live recall sessions, nobody is conducting. Yes, we do all the recalls live. Exam based filtering of the content is there. And ultimately, the unlimited access till you pass, no need to pay again and again. If you are still not sure, or you want to have my guidance for your exam preparations, then this is a free strategy call which you can book with me by scanning here. Okay, there is another question I can see here. Abundance is sometime answer to these scenarios when malignancy is suspected. So what lines change the answer here? What lines change the answer here is that the patient was waiting for a long time, and finally after 7 months she could get the operation theater. That is the main line which changed the answer here. Okay, so here are the three options for you all: attempting for July 25, going for 26. And if you are not clear, this is the call here. And thank you so much, Dr. Geeta. Yes, you are my student. I do recognize that. So here we finish our session today. And thank you so much for being such an amazing audience. I hope you all find it quite useful for you all. So thank you. Thank you for joining. And you can suggest to me further topics which you would like to hear from me for more such discussions in the description in the chat below. I'll be posting this video on the YouTube, I mean, as a content also, so you can always go back and check this out. Thank you so much for joining.